Dr. James Fernandes, whose work in pediatric limb reconstruction is unparalleled. So I welcome sir, and I'm really thankful for him to spare such a valuable time. And I'm also really thankful for other faculty members who have spared their valuable time for today's meeting. So our meeting will be first Dr. James Fernandes lecture and followed by the case presentations by other faculty members. And I'm also thankful for Dr. Shamsul, who is our joint secretary, Dr. Ashok Shyam, who is the editor-in-chief of Ortho-TV, Dr. Manish Prasad, who is our head of IT, and Dr. Neeraj Bijlani, who is the co-editor of Ortho-TV, for providing such a valuable technical support. And I'm also thankful for all the ASAMI members, our executive members and working committee members who are with us for today's evening. Thank you. So without wasting time, I'm handing over to Dr. Mandar Acharya just to initiate the proceedings and for the faculty introduction. Dr. Mandar, hand over to you, please.
I'm sharing the screen now. So good evening, everyone. So today's topic of ASAMI India's Grand Round is, as you all know, congenital pseudoarthrosis of tibia. And it's an honor to introduce Dr. James Fernandes, who is a consultant pediatric orthopedic surgeon, limb reconstruction at Sheffield Children's Hospital. He initially was trained in India, then at Liverpool and Sheffield Children's Hospital Center of Excellence, as well as he visits to many prestigious institutions abroad. His special interests are limb reconstruction, skeletal dysplasias, developmental dysplasia of hip, and general orthopedics. He frequently lectures at national and international meetings. His involvement in research has led to extensive publications. He has held various important roles in education and training programs. He has held quite a few notable positions in national societies, including past president of BLRS, Society of BSCOS, and chairman of World ASAMI branch. I also welcome Dr. Ruta M Kulkarni, president of ASAMI India. She is professor of orthopedics at Postgraduate Institute of Swasthya Pratishthan. She has many publications in national and international journals, has been teaching Ilizaro as a faculty since last 20 years in many conferences, and the main topics of her interest are deformity correction and limb lengthening. I welcome Dr. Satish Nesari, sir, who is assistant professor, Department of Orthopedics at BIMS Belgaum. He is a faculty of ASAMI India. He is honorary consultant at Weizgang University in China. He is a reviewer of International Journal of Limb Lengthening and has got publications in national and international journals. My colleague, Dr. Gurunath Wachche, is associate professor at VM Medical College, Solapur. He has undergone fellowships in Singapore and USA. He is an AO faculty. He is executive member of Indian Foot and Ankle Society and has got national and international presentations. Last, it's a pleasure to introduce my colleague, Dr. Ashish Ranade, who initially was trained in India in Pune itself, and then went to UK and US. He has done fellowship training in limb lengthening and deformity correction at Baltimore, Shriners and St. Christopher's Hospital, and also in pediatric spine. He has co-authored 4 book chapters and many publications. Currently, he is attached to Gurunath Wachche Hospital, Pune. So I will stop sharing the screen now, as we have done introduction of all the people, and I request James sir to proceed with his lecture.
So thank you all, especially to Mandar and Ashish for organizing this, and to Dr. Kulkarni as the president to welcome me as well, and Dr. Ravi Chauhan. And it's always a pleasure to be back on, we can't see each other in person, but at least on Zoom, which probably we are all also getting a bit fatigued since the last year as well. Anyway, so The remit of my talk is I'll give a little background of the condition, what we are doing currently in Sheffield. And we have done some review of our cases in the past, and we have recently reviewed our own type 4 Crawford cases and some case examples. I'm not going to give you extensive review or literature, but I'll mention a few things as we go. So, though commonly we call it congenital pseudoarthrosis of tibia, but it's a spectrum of disorder. As you know, anterolateral bowing of tibia comes under the same spectrum. So it could be mild, and then as it goes further, it goes to pseudoarthrosis. When it's truly, you got a absolute discontinuity between the tibia, or sometimes between the tibia and the fibula. By being bilateral is extremely rare, and association with neurofibromatosis possibly is in literature somewhere between 50 to 90%, and our own series is somewhere between 60 to 65%. 15% of these are associated with fibrous dysplasia and also the odd amniotic band syndrome. Now, you have to know a bit of neurofibromatosis, because I think the group of patients who have NF probably are more resistant to treatment rather than the classic one, which is not associated with any of the background syndromic condition. And NF, as you know, is hereditary, autosomal dominant. Again, it's a hematomatous disorder of the central nervous system, peripheral, as well as skin and skeleton. Also, we think that it may be rare, but actually it's the most commonest genetic disorder. And as I've been told by my geneticist, that about 1 in 3,000 people actually carry this gene. And 50% of these are all spontaneous mutations. Of course, this is for younger trainees. So if they are on the web, as you know, NF is classified to type 1 and type 2. And we normally see the type 1 associated with pseudoarthrosis of tibia, otherwise called von Reckling-Ossens disease. It's the defect is on chromosome 17. They have actually encoded the gene to the neurofibromin protein, which is the tumor suppressor gene, a key protein in cell growth and differentiation, also called as peripheral NF otherwise. Whereas NF2 is associated with bilateral acoustic neurofibromas and brain tumors. But the defect is on chromosome 22 and also called as central NF. They do not have much association with orthopedic manifestations. They're quite rare. This is a nice way for anyone to remember how to use the criteria. CAF spot or CAFE, SPOT. I'm not going to go through each one. If you have 2 or more, then the probability of having NF is high. One should also remember some of these signs may not be seen until the age of 5. And when you send them to the geneticist, occasionally, initially, you may not get the diagnosis, you may get it later on. So Cafale spots, the classic Cafale of what we call the coast of California, because they are smooth, unlike the McCune-Albright ones, which is called the coast of Maine. They get freckling of the axillary and inguinal region, fibromas, and if you have one single plexiform type, it's quite a strong suggestion association with the NF. Leash nodules in the eye are called pathognomonic. We always think as orthopedic surgeons that congenital pseudoarthrosis of tibia is more common, but actually scoliosis is probably more common. And the classic curve is a short angular, or sometimes you get the long C dysplastic. Hemihypertrophy is the least common association, and we have a few examples in our database as well. O stands for optic, and optic glioma of our series of almost, I think, 80 or 90 kids, at least 2 went on to develop optic gliomas. So what's the pathology? If NF is hematomatous, this one also probably is the same. It's a segmental dysplasia of the tibia and fibula causing the bowing and eventual fracture. This can be diagnosed antenatally or presents in first year of life with an obvious angular deformity. More recently, we have, in the last few years, we have understood it better, and we now know that the periosteum is at fault, and it is replaced by thickened invasive hematomatous tissue, which exhibits one, biological effects through increased osteoclastic activity, or mechanical effect constricts periosteal vasculature, and fibroblasts formed instead of Schwann cells or perineural cells. So for many years of our older literature, we were concentrating more on the bone, and actually the bone was not at fault. So what about the natural history? Is unfavorable generally. Earlier, the fracture leads on to more severe type of dysplasia and more refractory to treatment. Having recurrent fractures can have growth arrest and persistent deformity, limb shortening. And one of the problems, they also get valgus ankles, especially if the fibula also has a pseudoarthrosis. So there are many classifications, the older ones, and there are newer ones. And I suppose this is something not necessarily important for an exam, but probably most of in recent literature, we are using Crawford to some extent. And Crawford 4 is probably the worst one. And I think the Crawford 4 probably should be separated out from the others, because I think that group is the most difficult to treat. Boyd is almost similar, but it's 6 types. And we have got newer classifications of Paley's, basically talking about whether it's atrophic in nature or hypertrophic, and if one has had previous surgery and how stiff the pseudoarthrosis is. So in some ways, it helps you in the understanding of what technique to apply accordingly. Clinical features, if you see a child referred to you in clinic, you're going to look at the leg, of course, and if it's fractured, you'll see usually painless mobility. You may notice deformity and shortening. We went through all the clinical signs. Family history of NF is the most important thing you can find out. And sometimes they come as late presentations because it would not have been noticed in the initial years. That's a back to show you some cafe au lait spots. So what are the problems for us? A non-union or a deformity and leg length discrepancy. And for us, the goals of treatment is to obtain union or straighten the bone, prevent refracture throughout growth, correct the limb alignment and length at maturity. And since many of these neurofibromatosis children have other problems, you need to make sure they are seen by other disciplines. In the United Kingdom, we have special NF clinics run by endocrinologists or pediatricians, and they check them on a yearly basis. Ophthalmologists, as well as they check their blood pressures. They do in the adults, they do the VMA, vanillyl mandelic acid, to make sure they don't miss any tumors. I had a young child whom we picked up hypertension, turned out to have renal artery stenosis. So I think being pediatric orthopedic surgeons, I think it's our duty to make sure they are also managed for the other unfortunate complications of NF. Yes, prophylactic bracing can be done. We do clamshell orthosis in the younger child. It may protect until fracture occurs. It's very rare that we brace most of them to skeletal maturity. The only ones I may brace is where there's a very mild bow and the canal is absolutely intact. So that means there's an intramedullary canal and least likely to break. As they get older, you can free up the ankle joint. But one should remember, you can't cure the background pathology. So what surgical options do we have? I suppose if you go from history, and actually if you go back to Benjamin Joseph's original paper, and even when he goes and gives his talk on this, he will talk about how each of these techniques had some basis, and actually only when you combine these techniques, you tend to get the best results. So I've just put them in a surgical option as to stabilize or to realign. So you will use a method, intramedullary fixation, either with stationary or growing rods. In recent times, we're using minimally invasive plates made by Smith & Nephew, we call them EVOS, or external fixators, hybrid. I've intentionally kept vascularized fibrillar graft aside on this. And to get it to heal, you want some bone from elsewhere. So bone graft from the tibia or from the pelvis. Vascularized fibrillar graft, when you have a bigger gap, which nowadays, since I don't remove the bone so much, I don't need fibrillar grafts anymore. So we have stopped doing vascularized fibrillar graft. Periosteal wrap, I do use them. I'm not too sure to great extent, but when I use them at the back, where after the reconstruction, we do see extensive bone formation at the back as well. We use BMP because it does promote a lot of bone formation at the site. Originally, there was some problems for us as we are not licensed to use in children. But recently, after discussion with the management of the hospital and pharmacy, they have agreed for me to use on a special consent basis. There is anecdotal evidence that BMP can sort of produce tumors in the future, especially could be in NF. So we are not too sure about that. So I do inform my patients accordingly. There is quite a bit of talk about bisphosphonates, which probably started with David Little from Australia, and then Draw Paley has used it in his Paley X Union. Our metabolic physicians sort of are not very keen, so we are not actually using bisphosphonates. Stem cells, I think Brisha Madhuri from Vellore published a paper on it, though she said you might need more adjuncts along with that. Amputation is one of the options, but it's only reserved, I would say, for failed cases, though we have had patients who have been offered this on the continent as a primary option. What about success? If you look at literature, bone union is almost anywhere between 31 to 100%. But I suppose if you look at the older series, the most important thing of resecting the hamartomatous tissue was not being done. And probably that might be one of the reasons why the success rate was not, why the success rate was that low. But the refracture risk is still high, and most of the series is anywhere between 14 to 60%. And even the series of Paley's published by Tibet at almost 40% fracture rate. And also because different surgeons use different techniques, it's a little difficult to sort of look at results in a very properly manner or to use meta-analysis, because many other adjuncts and are used in the treatment more and more so in recent times. So vascularized fibrillar graft has had good results, if you see in literature, usually also stabilized with rod or internal fixation with good rates of primary or secondary union. But again, there's high refracture risk, non-union at the distal grafting site, valgus ankle, and also residual limb length discrepancy. This is one of our children who had a vascularized fibrillar graft, which had a good result. And finally, when she was an adult, she was discharged, though she did fracture the contralateral tibia, which I had to treat. Circular frames, the beauty of them, as we all know, being limb recon surgeons, allows correction of length and angulation and using a separate proximal osteotomy site to gain length. We felt that it was, at that time, should be combined with intramedullary rod to prevent refracture following removal of fixator. And it's also useful in the older children where rod alone has insufficient mechanical properties. But of course, one should remember, if you have a fixator and a rod, the chance of infection of the whole diaphysis is high. And we have had 2 such instances in my 24 years at Sheffield. Intramedullary rod is basically something to splint it internally and provide sustained stability. You may have to exchange it as the child grows. Of course, if you can't have telescopic rods, you can use rush nails or wires, and even for the fibula to aid stability. I am more and more now trying to osteosynthesize the fibula because their ankle scores are quite poor because of valgus ankles. And there's a good paper, of course, which came out from Korea. The main issue again is stability of the distal segment, and therefore you need, if you're avoiding a frame, you may be important that you have to put a rod through the calcaneum right across the ankle and subtalar joints, as first described again by Benjamin Joseph. Again, this is better in younger children if not supplemented with external fixator. To promote healing, periosteal wrap, which I mentioned earlier, I usually use a skin measure to make it even bigger. We now encourage tibiofibular synostosis. I do it in 2 rounds purely because our anesthetists won't allow us to harvest graft from both sides of the pelvis. They do have a lot of blood loss, and many of them are very small built. As you know, they are also finally have short stature as well, especially in NF. We do take quite a bit of corticocancellous grafts from the iliac crest. And I mentioned about BMP and bisphosphonates. There were in the past where we have used ultrasound and electrical stimulation. I suppose we are not too sure how good they are as adjuncts. Timing of surgery has been looked at. EPOS did a multicentric study. Unfortunately, it was different centers using different techniques, but they felt that surgery in the older child had better outcomes. And general aim for age, possibly 4 to 5, but best not to do below age 3. Occasionally I've done above the age of 2, but definitely not below the age of 2, depending on the type of treatment, as per Benjamin's paper as well. And of course, I still treat them in brace until then. Amputation, I would think if you have given 3 or more good attempts, thrown in the kitchen sink, and you have still failed, probably amputation is the reasonable answer. We have had 2, one who was treated multiply elsewhere, and one of mine who developed a tumor of the brain, and they are the 2 whom we had to amputate, and they felt really good after the amputation, purely because their life, you remove them of their misery of having a kind of flail, deformed leg. Just a few examples to show you to start with. This is H3 in 2013, where we have used excision periosteal wrap bone graft FT rod, and then again revision rod in 2016. So of course, this is an anterolateral bow of tibia, which we had watched, grafted, FT rod, went on to heal. And this is another one at age 3, same kind of concept, but see what at age 3, 5, and 9. So this is a true pseudoarthrosis. And everything was looking good, healing, but as time went by, migrated, developed a fracture through that site, used stacked Ilizarov to correct it. Though we got it to heal, of course, the fibula is still not united. The ankle is in valgus. And then that was at age 7. And at age 9, we went on to do the same for the fibula. Did corrective osteotomy, stabilized again with the intermedullary nail, periosteal wrap. And that's the end result with nice, reasonably straight, as well as the fibula osteosynthesized. Interestingly, once you osteosynthesize the fibula, I've noticed that the fibula starts to grow and tries to get the ankle mechanics quite normal. So it's very interesting how nature or Wolff's phenomenon and other laws of nature are working while you want to recreate anatomy. So we did an audit of first series in 2014, and we tried to look at internally fixed and externally fixed cases. And we tried to compare results before 1999, and I became a locum consultant in 1999 and then a permanent in 2000. So we wanted to see how our results were. Though it was retrospective, we looked predominantly at the case notes, radiographs, and questionnaires as well. Unfortunately, our returns for US score and SF36 were very poor. And we also looked at all this number of revision procedures, weight bearing, union, and complications. So we had 51 cases until 2014, which 10 were being treated at that time. 5 were unobtainable case notes, and 7, we didn't have a complete set of radiographs. You can see the age distribution, both for internal fixation, we're all in the younger age group, and circular fixators later age groups. Now remember, some of them will be tertiary referrals who have been treated maybe before. And if you see stabilization 50% with intermedullary rods and external fixation with 50%. And of the external fixators where we used, some had with the rod internal in addition, and we had a free fibular graft in 17% of them. a combination of angular correction and lengthening, as you can see, with when we use the frame, so which is the benefit of the frame. And in terms of results, though you may not be able to see each of those, pre-1999, it took us more number of revisions, and these revisions reduced after 1999. Maybe we started to do things a little bit differently. And the good thing about weight bearing, of course, if you use a circular fixator, we make them weight bear soon after, maybe 2 or 3 days after that. Whereas if you're using internal fixation, we'll be putting them in casts, and it could be anywhere between 12 weeks to 16 weeks before they actually bear weight. You can see the union of the pseudoarthrosis only. This is a bit earlier than internal fixation. And similarly, when excluding callotosis, the same kind of results. And we looked at and compared this pre-99 and post-99, and there was definitely some improvement in both these findings. We looked at also valgus ankles. As you can see, quite a few, 16% had valgus ankles with internal fixation, of course, less with external fixation, but of course, we couldn't analyze the reason. Probably we kept the alignment much more straight. One more thing, when we use intermediate rods, I'm seeing more and more valgus deformity developing at the proximal tibia, and very recently we've been adding guided growth at the top to realign them. So if you look at refractures also, both have had refractures, internal and external, as you can see. And pre-1999 and post-1999, also similarly around, possibly less after post-1999. But you look at infections, we have had our fair share. And I think, as you know, of course, it will be external fixators who probably will have a higher chance, and especially when we have a rod inside. And then we had to go and do rescue surgery for these when they get infected, and it is quite more difficult. And one of them had to rescue by doing a masculate type of technique to the interosseous membrane and getting them to unite, cross union between the fibula to the tibia. And I've got another one, which I'll show you an example later on, which is just coming down the corner. So we had amputations before 1999, and we didn't have till about 2018. And like I said, I've done 2, one from elsewhere who had multiple operations, and one of mine who had a tumor who finally decided to have the leg removed. So from this little audit which we did, overall, our rates of union, reoperation, and amputation were similar to other studies. And there were significant benefits of frame use regarding number of operations, rate of weight bearing, and union and amputation. So there was some distinct improvement in our outcomes from 99 onwards. Of course, the study was retrospective, unequal comparison between the two groups, and poor response to functional questionnaires. I think that's most important. We looked at our further series in 2018, and we thought we'll look only at Crawford type 4 this time. And we excluded all the others, and we looked at union rate, time to union, residual deformities, and refracture. And we had totally 23 who reached skeletally mature patients, out of which 60% had NF, 3 had vascular fibula graft, 7 X-fixes, and more number with rodding, of course, with the combination of excision of hamartoma and all the other adjunctive stuff. So overall union rate, again, is 70%, time to union around 7 to 8 months, refracture rate 30%, as you can see. Whereas with the vascular fibula graft, 3 of them, rough age was 6 years, time to union 7. Source of fibula, 2 was contralateral, 1 was ipsilateral, and the union rate only 2 out of 3, and residual malalignment in 2, which needed further correction. This is just one of the examples for the vascular fibula graft. Of the 7 external fixation, again, they were average age was 6.1, union rate 6 out of 7, which was 85%, and time to union 8 months. And you should see, still, you may have to bone graft further. So average number of surgeries were still 3 overall for this whole Crawford type 4. But they didn't have any malalignment at skeletal maturity. If you look at the rodding group, only 61% non-union, and time to union was 8 months. And those days, we never used to go to the ankle. So 2 out of 13. Residual malalignment was 53% and refracture rate of 53%. Another example, this is the old Sheffield rod, which we don't use in the tibia anymore. And it was further revised later on. But of course, this one is an example which went on to heal. So if we look at the groups and we compared our series to the series from Manipal, by Hitesha and Benjamin Joseph, and more recently, they published the big multicentric study where they had 119 patients. Of course, if you look at the refracture rate, 42% in that multi-centered group, we have about 30% here, as you can see. And these are all only Crawford type 4s, as you can see. Now, we do have a lesser union rate, but certain things which we are not using are also other adjuncts are not included. Very interestingly, in this paper of 2018, they felt that the BMP did not make much of a difference, which possibly we don't feel it. We think BMP has made a big difference in healing of our pseudoarthrosis. So the present patients whom I'm treating with Crawford type 4, average age, as you can see, 3.8 years, union rate is 80%, so we are creeping up. They're not skeletally mature and no residual deformities as such, apart from valgus, which we are treating with guided growth at the top end. So we compared this series as well, and that 2008 by Tebet is the paper from Drop Paley's unit. They had a refracture of 50% at that time. So subsequently, Paley has published about his Paley X union, saying he's got no refractures, but of course, they are still young and they have not reached skeletal maturity. So our current treatment is primarily the hamartoma, which needs to be excised. We still use Boyd's, depending on the amount of bone we need, either Boyd's tibial cortical grafts or corticocancellous from the hip. If the distal segment is short, I cross transcalcaneal, and I still use a wrapped periosteal graft. I gave you the reasons why I do the stages of trying to create the fibula and the tibia separately, purely because of operative time, bleeding, and safety. And we create the synostosis at the second round. And more recently, we are adding an additional plate. I'll show you some examples. So generally, we still follow Ben Joseph's protocol. So this is anterolateral bow with an early stress fracture. So you can see that we have used what is called a TST rod, which is half the price of the FD rod. That's why we moved on to that. And we use of course, in the middle, the incision is big. The rest of it, the plate is railroaded under the skin. And then we span, I use it like a spanning plate. So this went on to heal very well. And this is another one, type 4, as you can see. And this boy was very small, so we had to wait a long time before he reached at least 10 kilograms. And then he went on to have the same technique. We had revised him once because his rod we had to exchange and we had to push it through. And he's got his tibia to heal. Now his tibia is healed. We're waiting for the fibular osteosynthesis. Quite often I may use just an intermedullary wire, or we can use a smaller plate of the same company, which is quite nice and thin. This is unfortunate complication. I thought I should share it with you. Type 4 Crawford, I did the classic technique with the transcalcaneal upwards. If you see, all my bone grafts have disappeared gradually. Then we went on to use a frame and try to do bone transport. And even after that, the infection became quite extensive and we had to bail out. I had to remove, the microbiology team said that it grew a combined organism, and she also developed MRSA. So we had to completely bail out, remove everything apart from the wire, which I had to leave just in case, just to keep stability. And now all the parameters of infection are normal. And now I'm going to go back and do a stage to masculate through the intraosseous membrane, just like the one I did in the past. Unfortunately, I couldn't get those pictures for you because it's an older patient. I couldn't get them from my from a PAC system. More recently, as you know, this nice paper has been published by Mark T. Dahl, who came in JBJS. I always thought about using guided growth, but I wondered whether it'll correct a diaphyseal deformity to that great extent. But it'll be good for you all, whoever is keen. If when you see anterolateral bow of tibia, probably you could think of giving a lesser choice of using a 8-plate or guided growth in the oblique plane. As you can see, there's pictures in the oblique plane. This is the first one we have done after the parents agreed to it, after I showed them the paper. I think this is something we will be pursuing more and more for the anterolateral bow of tibia. So to conclude, it's still a challenging disorder, and though evolving treatment has improved results, though Paley says he's got 100% results, I'm not too sure why rest of us are not getting the same. There are many questions regarding the management of pseudoarthrosis, but they are all getting answered. I think the time has come to have an international registry. Tony Cooper from Vancouver is pushing ahead with that. I'll be part of it. And Hitesh Shah is also. And I think if you all want to be a part of this registry, do get in touch with myself or even Hitesh or Tony Cooper in Vancouver. And like I mentioned, I think for the anterolateral bow, guided growth may be a good option. At least 7 to 8 out of 10 will have reasonable results. Thank you.
Thank you, sir.
Thank you.
Presentation, actually. So, are there any questions within the panel? Dr. Mandar?
I haven't received any. Madam, you have.
Yes, thanks a lot for the great presentation. Thank you. I just wanted to ask, when do you use external fixator? Nowadays, you have stopped using Elizaro for CPT?
It is a reserve now. So primary cases, when they come to me, I'm using now intramedullary rod, plating, BMP, periosteal wrap, and I think I'm getting better and better results, I suppose. And we just then have to, only thing is you have to remember those plates have to be removed. I remove them at 12 months and then I exchange the rod to slightly thicker rod. If I go transcalcaneal, what I've been doing is then I will exchange that when I've got full union and the tibia is straight. I will then drop the rod through the knee and put a blocker if I need in the distal tibial epiphysis so that the rod, the male part of the rod doesn't drop off. Okay. Yeah, but the external fixator I have kept as for rescue operations, or if they come as classic hypertrophic type where possibly you can distract them. They're not that common at the moment. So I've done a few where I've got successful results in my initial series. But yes, you're right. There is a little drive in how things are moving on in our unit or in the UK, maybe. There's a slight drive to move away wherever we can with external fixation to some extent. I'm sure patients in India also may not prefer the external fixator if you give them internal fixation choices, I suppose. Yeah.
That's true.
I have a question, if I may. It was a great talk. You mentioned about using mascale technique. Could you tell us a little bit more
so
about
it's
that?
A modified, it's not a classic mascale. So basically, let's say the tibia got infected and then quite a bit of the area will have to be resected. And then if you have to try to get more bone, most of the time we might have taken bone grafts from the hip already. So what I have done is we do a first stage through, depending on what incisions we've used before, I lay a complete thin sort of antibiotic loaded cement inside that above the intraosseous membrane, right across from the top to the bottom. Preparing the fibula already, and so that when I come back in 6 weeks, that part will have enough of new membrane. And that's the time I use bone graft from the posterior part of the pelvis, because you get good cancellous bone. Use BMP and then lay the whole thing. So basically it produces a sheet of bone connecting the proximal tibia to the fibula and the distal tibia to the fibula. So that's what I've been, so the one was very successful. I think we did 2. This is another third one, which is coming up. And then I'm doing one for an unusual infection in osteogenesis of the tibia, where the tibia is disappearing. So that's like an unusual type of mascale, I call it. Yeah.
Thank you.
Sir, James sir, thanks for the nice presentation. Actually, I'm having one question that in the younger children, just 2.5 to 3 years, and if they come with the fracture, with the severe deformity, so is there any tips and tricks for acute correction? You don't get neurovascular issues.
In neurovascular issues, you mean?
While doing acute correction for the nailing and
No, generally not. But yes, quite often, I'm not saying I previously I used to resect more bone, whichever was dense. Now I don't take that amount of bone. What I do is, even if it's dense, I recreate the canal and then prepare with multiple drill holes on the cortical surfaces by cooling it. And then I think because we also add a rod inside and then put BMP and cancellous bone, the healing is much better. So my amount of resection of bone is become less and less. So even if you resect, you can shorten a little bit, then there's no big problem with the neurovascular structure. So I don't actually bother that amount to keep the length. You can shorten a bit, and then you can avoid even contralateral Boyd's grafts as well, the tibial grafts. That's what Benjamin Joseph published in his onlay type of technique, which also I've done a few times, and they're quite good as well. But I use them only when I need to fill a gap. Yeah.
Thanks, sir.
I have a question.
Okay.
I have a question. Ravi?
Yeah, Dr. Satish, please go ahead.
James, sir, very nice presentation. You covered almost all the aspects from beginning to end and the recent methods also. I would like to ask you a question regarding what is your protocol for lengthening? When do you lengthen? And what is the age, or when do you recommend lengthening?
Lengthening in general, or specifically for this cohort?
For CPTs.
For CPTs. Oh, yeah. So basically, the main initial treatment is mainly for union. So that's the critical thing. So once we have got union, then we only look at what the final height of the child is, whether we can use contralateral epiphysiodesis as part of the technique to equalize them, and the odd one, possibly where the length difference is going to be significant, then yes, we will use an external fixator to lengthen, depending on what the final LLD is predicted. So I don't have a clear-cut, what to say, an age for that, unlike, say, let's say, congenital short femur or PFFD. But these are based on what the final prediction is or what complications we have seen. Only then will I consider lengthening at the right time.
Is there any cutoff point or anything like that, like 5 centimeters, 6 centimeters, anything?
Yeah,
like
so
that?
I use a combination of both final height and 5 centimeters or more. So those two things. So anyone, if the parents and child feel that they are eventually going to be short. Now, NF children won't be tall. So you have to really talk to them and ask. Now, NF also are prone to more complications with their treatment when you go a second time or a third time. So we do counsel them a lot, and they also well versed. They check on literature and everything nowadays, and then decide. But yes, we have lengthened more than 5 centimeters. Less than 5 probably I'll err on the side of contralateral epiphysiodesis unless they're going to be really short.
And if you plan for lengthening, what is the rate and rhythm you?
So I think first is the site. So if you're going to go to the proximal metaphysis, where most of these pseudoarthrosis are not affected, then I think the rate and this one can be dictated by whatever, depending on age and depending on what type of technique you've used. Because we all use the Ilizar corticotomy, I may do anywhere between 5 to 7 days. So that will be the thing. But there are some pseudoarthrosis of tibia where when you see lesions right going to the proximal tibia, they are the ones you have to be careful. So the ones where we did resection and vascular fibula graft, they were the ones. The one which failed was exactly at the top end. Also, it did not heal because there were lesions right at the top as well. So I think you have to look at, and I think that kind of condition may not be The NF type, it's got something more than NF, like a fibrous dysplasia kind of pathology extending top to bottom. Yeah.
Thanks a lot, sir.
Do you aim for cross union between tibia and fibula at the fracture site?
Not at the first time, purely because you need a lot of graft. I don't know whether you came to Brisbane. Dror and Mark Dahl had a big argument because he was talking about taking cancellous bone from both the iliac bones.
Yeah.
And I think one child of his had 4 units of blood loss, which possibly is 4 times the child's volume.
My God.
And so we are not that, we try to be very safe. And I also look at the weight of the child. At least they have to reach more than 10 kg or minimum, even for sort of to make sure that I'm not very aggressive. I don't mind coming back and do a second go for the fibula. And that's the time I will deal second round, the fibula osteosynthesis, and then try to create the synostosis at that point. Now, interestingly, there are 1 or 2 without attempting synostosis. There was one example, went on to synostos. So I'm sure BMP also goes around and then does some wonderful things. Yeah.
Sir, James sir, there is one question from the audience. How do you fix when there is a small distal tibia?
Yeah, so that's the reason why then you have to change your plan for the rod to be transcalcaneal. So it has to be a retrograde rod, which should have some kind of threads to purchase in the calcaneum. You can still put a plate because there will be at least, you can put 2 screws at the bottom. You're putting a spanning plate on top of it. So you can still do that. But yes, those distal ones, definitely, you need a transcalcaneal intramedullary rod.
Thanks.
James, I have a question.
Yes, proceed, Dr. Mandar. You can.
So the question is that while resecting, always do you get transverse cuts, or when there is a sclerosed tip, you try to put one into another?
Good. That's a good question. So that is like pushing a spigot into a canal. So the one, I think the second example I showed, that's what we did. We pushed that little tip of the atrophic one into the distal segment, which we have made it like a little spigot, split it a little bit open, like you cut it like a Mercedes-Benz, and then you sink them together. And then you put all your bone graft around. So yes, that's a good technique as well. So I think that used to be, I think it is called the Winnet-Orr method in tibial fractures. Do you remember? Winnet-Orr, old books will give it. So Winnet-Orr, I think, described it for tibial fractures in non-union where the atrophic site was jammed into the canal of the distal site. Yeah.
Thank you.
I think in your experience, sorry, sir, in your experience, have you seen the patients with limb length discrepancy? They will catch the growth at the end of the maturity.
I don't think so. There are other conditions where we have done one lengthening, and then we think there has to be another one. So there has been. There's a bit of evidence somewhere. They say, I don't know whether it was an achondroplasia. If you lengthen in girls below the age of 9 and above the age of 9, there is some growth inhibition, whereas growth acceleration is also possible. So yeah, you are right. But I don't think in pseudoarthrosis, because you do lose quite a bit of length, it does not catch up to the same extent.
Sir, one question. If you compare both the modalities, intramedullary fixation and external fixation, how you decide how much to excise and what is the end point in both the modalities?
Both the modalities is the same. I will still now I think that the bone is normal, according to me. So so I want that bone to prepare to accept the nail or rod which I'm putting inside. That's all I do. And then however way you want, if you want to impact, like the previous example I gave, you can impact the narrow one into the distal tibia where you can open up the tibia by 3 cuts. It splits open. You can do that. But I don't resect bone anymore unless required only for preparation to get a rod inside.
they say that you should excise till the punctate bleeding. That is the previous thought. Is it the same concept or the concept are changing?
I don't think, I don't wait for, because they're all under tourniquet. To see punctate bleeding is not that easy. But I'm not very, because when we remove bone graft from elsewhere, they are also dead. This is also a dead graft. So I don't think it makes much of a difference from that point of view. I do not actually, I used to resect a lot in previous years in my initial career, but I've moved away, and I think all for the better, according to me.
Okay, thank you.
Someone has asked, how do you fix when that is answered? Yeah.
Yeah, so that is answered.
Can I ask one more?
Yeah, ma'am, please.
Yeah.
Yeah. What about ankle valgus? How do you treat it?
Okay. That's a very good question you said, because I was thinking about it, because all our older kids were all like developing calcaneovalgus feet because we ignored the fibula.
Yes.
And I started to gradually osteosynthesize the fibula, and somewhere in one of the meetings, someone said, why do you do that? And very interestingly, at another ASAMI meeting, was it Choi or one of the Korean papers they published as well, where they looked at ankle scores after doing fibular osteosynthesis, they were far superior. And I'm now more and more particular about getting that fibula to unite, even where I have solitary pseudoarthrosis of the fibula with a very mild bow of the tibia, I will osteosynthesize the fibula.
Okay.
Purely you will see migration of that fibula a bit more posterior at proximal, and that is good enough for the ankle to go into valgus, and their ankle scores are poor. Yeah.
Sir, there is one question from Dr. Jhinjirwala. Jhinjirwala, sir, please unmute yourself. Please go ahead, sir. Yeah, you are audible.
Yeah. After pseudoarthrosis heals up and patient falls down and get a fracture of the tibia, what treatment you give?
Yeah, same thing. We every child, if I have to use growing rods, at the right age, I actually exchange the rods to bigger rods. So as long as there's an internal rod, we are not worried. But we don't want any patient without a rod inside at the moment. And usually at adulthood, what I do nowadays is I actually exchange the final rod to an adult humeral rod. I put a humeral rod, which is 7 millimeters, and then drop it down. The humeral rod has got the same angle as the tibial rod. So I just use that, and that's usually what the final treatment is. Yeah.
I had 2 cases like that, and in my cases, I don't use rod.
Yeah.
It is the Elizaro treatment we give.
Correct.
And in those cases, I put plaster immobilization for 6 to 8 weeks and fractures healed up.
Yeah, but we have had here where people have done that elsewhere, but then we have got non-union as well. So I think it's all a bit of a matter of, depending on what the original primary treatment was. So if you have excised the hematoma, probably they might go on to heal.
Thank you.
Thank you, sir. So, Dr. Mandar, now we can move to the next presentation.
Yes. So the next presentation will be by Dr. Satish Nesari, sir. I request him to unmute.
Okay.
Share.
I will share it now. Good evening, everybody. I thank our President, Dr. Ruta Kulkarni, Madam, for giving me opportunity to present my experience in our civil hospital, Belgium. So I am from Belgium. So I pay my tribute to the great Elizaro surgeon, who is a great scientist, philosopher, academician. On June 15th, we will be celebrating his 100th birthday. So with this, I would like to start my case presentation. This is a 10-year-old boy residing in a tribal area, came to Civil Hospital Belgium He was brought by a social worker, local social worker. According to the parents' history, the deformity gradually progressed when the child started walking at the age of 2 years. It gradually worsened. So initially, the parents used to take him to the school. Then gradually, he started walking with the help of support like crutches or a chair. So this is the X-ray. Sorry for the poor AP view. This is a pure Crawford type 4 CPT with pseudoarthrosis of tibia as well as fibula at the middle third, lower third junction. So I proceeded with excision of the hematoma and excision of the bone with IM rod inside. And I harvested iliac periosteal graft and cancellous bone from the iliac bone, and also did the excision of fibula pseudoarthrosis. So this picture shows the excision of the hamartomas tissue as well as the tapered end bones. So here the periosteum has been harvested. So normally I elevate the iliacus muscle and then incise the periosteum or the inner table of the iliac crest, and then excise a rectangular or a square type of square shape of periosteum, and then harvest the bone graft with minimal damaging the iliac epiphysis. So this is how the periosteum is wrapped around the ends, bone ends, and then graft is inserted. So this is the immediate post-op picture. I used a three ring frame, hybrid frame with all wires in the proximal as well as distal ring with one shank spin and one wire in the middle ring. So this is the immediate post-op picture. This is how it looked. It's a intramedullary wire inserted from the calcaneum, and the patient lost for follow-up and landed to me with after 2.5 months of the initial surgery. By this time, the pseudoarthrotic site already started healing, and so after 2.5 months of the initial surgery, I did a corticotomy with distraction of 0.5 mm per day. So this is 1.5 months after doing a corticotomy. At the time of corticotomy, I inserted an additional shank spin in the proximal ring in order to have a good stable base. So I continued the distraction 0.5 mm per day, and at the end of 3 months, I could get a 6 centimeters lengthening, and with a good regen rate. And after 4 months after stopping the distraction, this was the picture with a good regen rate formation and a complete union of the pseudoarthrotic site. And after 6 months of stopping, or 1 year after initial surgery, this was the picture. The patient had absolutely no complications, no problem, and this is the picture before removal of the fixator. So after removal of the fixator, I applied Aboni cast for 2 months and later converted into Bijlani cast. So this is the picture after removal of the fixator and when the patient was in Bijlani cast. So this is the video of the patient walking. This is during the distraction phase, and this is during the consolidation phase, patient walking comfortably. This is the patient walking with the Bijlani cast And this is the recent picture, that is 2 years after the initial surgery. Patient is going to school and he is independently walking. So these are the clinical pictures. He is going to the school, and the limb length discrepancy also has been mentioned, maintained. So external fixation time was 12 months. So it took 6 centimeters for 6 centimeters lengthening. It took 3 months, and additional 6 months for consolidation phase. So the pseudoarthrosis healed within 3 months, and the patient was comfortable throughout the procedure. Thank you.
Thank you, Dr. Nesari, for such a nice case presentation. Any question from within the panel?
That's a nice result, to be very frank. Yeah. I just wonder whether having a rod in that may benefit you in the future.
Yeah, I need to remove the rod and insert it from the proximal side, sir.
Well, that's a good result. Yeah, but I think because the refracture rate, if you look at all the series, when you don't have something inside, probably maybe having an internal splint comes in handy. Yeah.
Junjunwala sir, you were having a question.
Yeah. I do mostly the same type of treatment, but I don't put grafts. I don't take iliac graft, or I don't put any graft. Because the osteotomy also, I do the same time, same surgery, same sitting. And when you start lengthening at this osteotomy site, there is increased circulation, which helps to unite at the pseudoarthrosis level. And therefore, there is no need of graft, I feel so. In all my 14 cases, I never put graft, and still all 14 cases healed up well. Thank you.
Yeah, please, Dr. Gurunath.
I just want to ask James sir about this case, whether any need to fix the ankle in this case to prevent the lateral valgus deformity?
At this moment in time, I think I can't remember the last X-ray. It may be worthwhile. I suppose to get a better result, it's worthwhile. If it's borderline, maybe it's okay. But I think if it is definite, because as time goes by, if that fibula migrates, then you will start to get into trouble.
So in the last X-ray, the fibula healed, sir. It has healed.
Okay.
And also the intramedullary rod, it helps in getting a good stability and early union at the pseudoarthrotic site.
Is it a good idea to do tibiofibular fusion prophylactically to prevent further ankle valgus?
We do not know as yet how many in the future, after creating a synostosis, will still develop valgus, I think.
Probably with the long-term transarticular pin, it will go for ankylosis.
Okay, so you will produce ankylosis purposely because of the one. Okay.
But you could change it. So I do remove and then exchange it from the top. So you could change it and put a kind of different system, or TST rod, even a single rod if you want, a female right down and then leave it there, and then.
So in that case, with FD nail with that locking hole will be available. That would be better.
See, the thing about the FD nail, to put that little wire, it takes you more than an hour, unless you are so lucky. So I don't try to. Of course, we don't use the FD rod anymore because they charge phenomenal amount of money. Yeah. So I don't see a big difference, because I do a lot of osteogenesis. We use a lot of growing rods, and they all have the similar problem, even if you put a wire or anything, because there is no purchase at the top end anyway. You can get the rod pull through or push through at both ends. So I don't think there's any great superiority by putting a wire. I know that Raw Paley has made the company Pega make some special rods just for him. And if you see, those ends of his male are totally different in his pictures, if you see. So they are different. So the standard Pega FD rods are mainly made for osteogenesis, and very few of us actually put a wire across. It takes a lot. It's less than 1 millimeter in diameter. I don't know what Dr. Kulkarni has to say about putting a wire through that. It's like a needle in a haystack.
I agree. It's extremely difficult to negotiate that.
Yeah.
It will take a lot of time and radiations.
Yeah, yeah. Your anesthetist will be after you, at least in the UK.
If there are no questions, then we can move ahead, Dr. Mandar, for the next presentation.
Yeah, I request Dr. Gurunath Wachche to present his case.
Good evening. Myself, Dr. Gurunath Wachche, Associate Professor Orthopaedics, Dr. VM Government Medical College, Solapur. I just want to share one interesting case of congenital pseudoarthrosis tibia, which was treated in 2001 with the Elizarov external fixator, ring fixator, with the proximal corticotomy. So the 7-year boy presented to me with the severe congenital pseudoarthrosis tibia. As we all know, this is the most challenging and controversial topic in pediatric orthopedics. So the patient presented with severe anterolateral bowing deformity at the junction of middle and distal third of the tibia, and he was walking with a difficulty, but he was with short limb gait. There was no any significant obstetric history. His milestones were developed at appropriate for his age, except walking. The associated problems were he was having short limb gait and severe anterolateral bowing deformity of the leg. His ankle was in the valgus, and interestingly, the foot was very small size. My aim was to achieve and maintain union simultaneously, providing the functional extremity. So you can see the preoperative clinical photograph. So much of the severe deformity. With such a deformity also, the patient was walking with somewhat short-limbed gait. This is the preoperative X-ray, which confirms the severity of the condition, and you can appreciate that there is almost 90-degree anterolateral bowing deformity with pseudoarthrosis of the tibia and the fibula. So my planning was longitudinal incision, lazy S-shaped incision, excision of the CPT segment as far as possible, then acute docking considering the neurovascular status with temporary intramedullary long K-wire to prevent the translation or any deformity on the site, and then application of the pre-assembled Elizarov fixator and with the proximal corticotomy with the same sitting. The intraoperative findings were the CPT site was very stiff at the fibula and the tibia. There was a very little mobility, and there was complete blockage of the medullary canal, and the neurovascular status was normal even after acute docking. The total surgical time was 5.5 hours. The tourniquet was released in between. It was done in the spinal anesthesia. This is the immediate post-op X-ray. You can see the excised CPT site with Elizarov fixator in situ. This is the proximal corticotomy site, and here I have used the olive wire to maintain the translation. These are the follow-up X-rays. You can see the CPT site is in reduction position, and the regeneration is progressive. You can appreciate the regeneration in AP and lateral. These are the clinical photographs under treatment. This is the photographs with distraction in situ. You can appreciate the formation of the cortex in AP and lateral position. But here I found that there was little bit procurvatum deformity at the proximal fragment because the proximal site fragment was very small, and probably with so much of distraction that was going in the procurvatum deformity, but I felt that it should be kept like that. These are the follow-up distraction X-rays in progress. You can see the slight union at the CPT site has already started. And now you appreciate the good regeneration and uniting CPT site. These are the almost final X-rays before the fixator removal. The almost 4 cortices are well developed and the CPT site is also in uniting position. So this is the final X-ray after the union at the CPT site. And these are the X-rays just before the fixator removal. See the regeneration quality and the united CPT site. So my post-op protocol was distraction started after 4 to 7 days, daily 1 mm distraction. Total regeneration was almost 6 to 7 centimeter. The fixator time was 1 year and 4 months. And post-fixator removal, I have given the protective caliper for almost 2 years. So physiotherapy, post-op physiotherapy and pin tract care is also very important. You can see patient doing physiotherapy with fixator, Elixir of fixator with the foot frame, the knee movements are almost full and the ankle in normal position. So this is the X-ray after the post-fixator removal X-ray, united the CPT site, good regeneration, and with there is slight procurvatum deformity at the proximal corticotomy site. These are the 1.5 years follow post-op X-rays. Good formation of the cortex in apian lateral position. These are the 2 years follow-up X-rays. You can appreciate the regeneration. There is no fracture till 2 years. So these are the clinical photographs. These are the post-fixator clinical photographs. You can appreciate the foot size is very small. These are the photographs with caliper for 2 years to prevent the refractures. And this is the follow-up X-ray even after 20 years. So you can appreciate that this is at the age of 7 years pre-op. This is at the 9 years after the caliper removal. And this is at the age of 27 years of the age. So this is the follow-up X-ray after 27 years. You can see the procurvatum deformity is almost corrected. There is slight varus angulation at the CPT site. Foot size is still small as compared to the normal size, and the heel is also hypoplastic. So this is the clinical photograph, lucky surgeon and happy patient after 20 years. So these are the clinical photographs. So thanks to Dr. Shekhar Chudgupkar, who has given me opportunity to treat this case at Chudgupkar Hospital in 2001. And this is the OT team. Thanks to the OT team. Thank you very much.
It was really a nice case with excellent results and such a long and good follow-up. Really nice.
So can I make a comment, please?
Yeah, ma'am, please.
Yeah, so Vachche, a very good case result and follow-up.
Thank you.
But I think it was not a dysplastic type of pseudoarthrosis. It was a stiff type of pseudoarthrosis. And yes, such pseudoarthrosis can be treated just by distraction. If you just distract and correct the deformity, you can have union. That's my experience. So if the bone ends are not dysplastic, you may not even have to resect the pseudoarthrosis, especially if it's a virgin case, if it's not operated before. So you can just distract and these unite. So James, sir, do you have any comment?
I think I would agree with you. Yeah. So I think they behave, I think when they have the stiff non-union, they are not like, I don't think they have the classic hamartomatous, too much of a lesion. So I think under distraction, there is change and, new bone forms. So we have done a couple, when we used to do more fixators, and we don't get such severe cases late in this country. So, but probably you will be seeing it more in India and Africa. So yeah, I would fully agree that you could have attempted without resecting, but yes, you have got a good result, no doubt, which just possibly would increase your frame time, if at all, I suppose. But it's a good long to 20 years. You know, you like you say, so, you know, not all the time we are lucky. I think I'm not saying you are lucky. You have done your technique quite well. The only other thing, that's the little tip to prevent proximal procovatum deformity. So tibial lengthening, when you start doing anything more than 4 centimeters, usually will get valgus procovatum deformity. So one of the things in Kurgan many years ago, what they do is they call it the anteromedial open ring. So your first ring, I'm sure many of you know that. So if you set your ring not parallel, but it is more open medial, and you set your 4 rods or 3 rods, you set them in an oblique plane of an anteromedial hinge at that ring. So at the end of your treatment, it's called preempting the deformity. So you know the deformity is going to come because you're going to go for 6 centimeters of length. So at the end of your lengthening, you do asymmetric distraction. It actually does an oblique plane correction at the same time. So just a little practical tip if you want to use for future cases, though the child has done well into adulthood. Yeah.
Yes, sir. Thank you.
Thank you. So I request Ruta madam to present her case.
Okay, I'll share my screen. Okay, so my case. Sorry for that. Okay, it's visible?
Yeah, ma'am, please go ahead.
Okay, so my case is this 6-year-old girl came to me with this deformity and shortening. She was operated 3 times before she came to me. You can see all the scars here. And even Elizaro was done by someone else before she came to me. So this was her X-ray. You can see the bony ends are tapering, dysplastic. And there is osteopenia also. There is deformity and shortening. So I did resect the pseudoarthrosis. I resected the hamartomatous periosteum, which is the most important step, both in tibia and fibula. And then I put a rush rod, retrograde rush rod, because the distal fragment was very small. So from calcaneus to talus ankle into the tibia. And then I put 4-ring frame, the foot ring, the distal fragment has 1 ring and the proximal fragment has 2 rings. I did corticocancellous bone grafting at the fracture site, did corticotomy above in the same sitting and started distraction there. So you can see the regenerate is now consolidated very well, and even the pseudoarthrosis is showing union. So almost after 9 or 10 months, I got good union, and then I casted her for 3 months and put her in brace after 3 months, and she walked on the brace and the rod broke because it was a thin rod. So I removed the distal part of the rod. This is her 4-year follow-up. The remnant of the rod is now a souvenir, lifelong souvenir for her. But she was doing quite fine. You can see there is no limb length discrepancy and there was no deformity. And this is her 10-year follow-up X-ray. So she has just 1 centimeter of limb length discrepancy, but full function and absolutely no refracture. She didn't use brace for a long time after that, but the rod was acting as a splint inside probably. So she did quite well. This is a similar case. This boy was also operated twice before he came to me, and there is, you can see the scars. So I did the same thing. I followed exactly all the steps, but you can see this time I put a thicker rod here. And you can see corticotomy and regeneration, and even the CPT is uniting. I put a rod in fibula this time. And this is after removal of fixator. He is in cast for 3 months and then brace. He was walking in the brace, but after 1 year, I removed the retrograde rod and put an antegrade rod. This is again a square nail. And this is his 9-year follow-up X-ray. So he was actually lost to follow-up and he came very late, only after 9 years. He is doing quite well, but the ankle has gone in valgus. There is proximal, the distal tibia has procurvatum and valgus deformity. So I offered him a supramalleolar dome osteotomy to correct his deformity, but he blatantly refused any surgery. He was quite happy with the result. Thank you.
Thank you, ma'am.
Yeah, I think that's nice result. I think having an intramedullary rod does help, and I think the fibula is very important. I think we have been ignoring for a long time. I think overall you got a very good result there for both your cases.
Thank you.
But I think another problem we have in the Western world is because many of them want to go back to sport.
Oh.
See, so when they want to do sport and everything, the chance of refracture rate is high. So having something inside does help us, because even if they do something and they fracture, at least it just breaks and you can treat it even non-operatively for some time. I don't know how much of our patients' children in India eventually do, if they have to break or fall, they have to fall from, if they're not doing sport, that has to be something significant, isn't it? But yes,
we would advocate them not to go in sports, actually. We won't take that risk.
We can't say that here. They will ask first is, can I go and kick the football? Especially for, even girls, yeah.
I have a question, sir.
Yeah.
James, sir, in Ruta Madam case, if suppose the patient agreed for an osteotomy, corrective osteotomy, how do we deal? Should we plan the same way as we plan for CPT, like bone grafting, osteotomy, bone grafting, and then?
I would think so, because the original pseudoarthrosis was very low. Though we excised the obvious hamartoma, I wonder whether some of the pathology is still there behind, even more distal than what we think. Only problem with all these, which we also had in our original series, is they do have like a calcaneal valgus compensation with the distal tibial valgus procurvatum at the distal tibia as well. So you may have to be careful how you think when you do a dome, because your foot will now, from a compensated position, may go to a decompensated position. So it's a little, I would say, a middle path somewhere to make sure that the foot is still plantigrade and has got still some movement in the subtalar joint to compensate. If the subtalar joint is also lost some movement or becomes stiff, then it becomes a bit more difficult. So you may have to compromise on the way you set it. But yes, it's still a risk in that area where possibly, chance of healing is still not the greatest. And if they're associated with the NF, I think I would, I would be even more cautious. Yeah.
Yeah, this particular boy didn't have NF, basically, and he was skeletally mature. He was almost 16, 17 years old. Yeah. And I was planning to do a supramalleolar osteotomy very near to the ankle, very low supramalleolar osteotomy, including fibula, and turn that ankle. His subtalar joint was supple.
Okay.
So, but anyway, probably I was saved because he refused. He refused it.
So, sometimes I also say, listen to the patient as well.
There is one question from Dr. Vigneshwaran that about the tibiofibular cross union. Basically, he's asking just to reduce the refracture rate. So, James sir, what's your take on how often you go for tibiofibular cross unions? And Dr. Satish also, do you keep in mind about the tibiofibular cross union during your management, because in your case presentation, your case was not having that? So do you keep in mind that?
asked him this question before to James.
Yeah, yeah. So cross union, the only reason I don't go in the first go is it takes a lot of time. You need a lot of graft. And if you want real good graft, you have to take it from both sides of the pelvis. The
Yes, sir.
bleeding is a lot. The time of surgery extends quite a bit. For us, at least, the anesthetists become very twitchy when there is quite a bit of blood loss in a small child. So that is why I do not do. So I go in stages. I would rather go in stages, be safe, than go in one gung-ho moment of doing everything in one. It's all possible, but in the United Kingdom, if things go wrong, if you get sued, you'll be called negligent very easily. It's not the same in the United States to some extent. So if you are a top surgeon, it's unlikely you'll get, even if it gets sued, there are very few people who will counter you. So yeah, so we do it purely because of safety rather than anything else. Yeah.
And refracture in CPT after union is probably because of residual deformity. If there is any residual deformity, it will cause a stress over the CPT site as well as the proximal to the CPT site, and that's how they land with refractures. So we have to correct the deformity properly.
So the benefit nowadays, because we are using more and more guided growth, the subtleties of, say, proximal tibial valgus or distal tibial valgus, we can manage with guided growth. They do correct reasonably well. So I've used screws at the ankle. I've used sometimes O plates or 8 plates. I see now with using that plate on the medial side, I am getting overgrowth on the proximal medial tibia. So I have to add another 8 plate at the top as well. So, but these are simple procedures and you can keep maintaining alignment and have something inside. You're absolutely right. Anything bent is prone to break. You're absolutely right.
And sir, for tibial synostosis, you said you prefer to stage the procedure just to avoid the bleeding and all that. So is there any time interval after the union of tibia CPT that you prefer to go for second stage? Is there a time interval between that or such?
The time interval is not kind of definite time, but union and canalization of the tibia is important. You need a canal, nice canal scene, and then I will time it. We also have a little other timing things in the UK. We don't operate on important years of schooling. So I don't operate when they just join school or nursery. I'll do them after they go into year 1 because they have to settle in the school. We organize a lot of things so that they get support in school as well. So lots of things, though textbook and people say, you do it like even draw will say is PFFD, you'll do it 2 years, 4 years, 7 years, or no, we don't go according to that. Because it's not someone's legs, or it's all about the family and the society you live in. So it's the same for you all. When I come to India and do work, when there's harvest season, nobody wants to come and have surgery, isn't it?
Yeah, definitely.
So it's the same philosophy. So you need to, so I don't have hard and fast rules, but I will use fitting and to the benefit of everything. So yes, but yes, main key thing, the tibia has to be absolutely nice and canal should be nicely formed and caught in. Yeah. Then it's easy because then you're only tackling from the anterolateral side, from the fibular side, lifting it off to the tibia, and then you can do a nice synostosis.
And we don't know how feasible the procedure of cross union in our setup.
Yeah, I suppose your limitation may be BMP is too expensive. So I don't have to take so much of graft because I use BMP. When I take the graft, just like you, I take the graft from the inner table only. I don't take the outer table. And I take the periosteal wrap from within, just like you showed. I think you showed that case, isn't it?
Yes.
Yeah, so it's the same technique I use. However much the periosteum you remove, finally when it comes in your hand, it comes as a 50 pence per patch.
Actually, we have to make a mesh out of it.
Yeah,
so like we do skin grafting.
That's what I do. We use a skin mesh, yeah. But yeah, that's correct. You're right. But that's why, I try not to do everything in stages. Yeah.
And regarding the cross union, sir, before Dr. Pale, Choi was the one who started cross union.
Absolutely, you're right.
And the cross section of the cross union site was less in Choi compared to Dr. Pale. So that's why the refracture, he claims that the zero refracture rate is because of a bigger cross section area of cross union.
I'm not too sure about that, but we do not know. There are lots of things. I mean, with due respect to him, we find it difficult when the rest of everybody gets sort of complications, and some of us, it's very difficult. It's like Sujaka's osteotomy. Yes. He had such great results, but nobody else could repeat those results. So.
Are there any other questions? Dr. Mandar?
Yeah, if there are no questions, we should proceed.
Yeah,
I request.
Ruta ma'am, we can proceed with the conclusion if there are no further questions.
Okay, so it was a great discussion. Thank you very much, James sir, for joining in and giving us the overview of Mandar is raising his hand. Yeah.
Ashish has to present the case.
Oh, I'm so sorry. Ravi asked me to conclude.
Yeah, so. that was about your case presentation.
And Ashish can then present.
Oh, I'm so sorry.
Yeah.
Ashish,
so I request Ashish, you present your case.
Yeah. Thank you. I'll be quick.
Take your time, Ashish.
It will be, we are approaching. So it's a case that me and Mandar did together. 2 years, 7-month-old girl with neurofibromatosis 1. She had X-rays done somewhere else, and I thought that probably it's a cystic type, but to my surprise, it fractured somewhere else. It fractured distally. So she came to me with this picture, and considering her age, we did the onlay tibia grafting using Dr. Benjamin Joseph's technique. We harvested graft from the medial side of the tibia and put a transcalcaneal rush rod, and that's how it was. It went on to heal well. We put her in a cast for 3 months, and around 3 months time we started weight bearing. At 6 months we did a check x-ray to make sure the bone is healing on the opposite side, and it went on to heal well. At 15 months her leg lengths are almost equal, slight difference. She's managing well with the clamshell orthosis, and then that's how she is at 2.5 years. So at this point we are planning for rod exchange. We'll continue with the clamshell orthosis, but now listening to Mr. Fernandes' talk, I'm wondering whether I should add a synostosis across this site. Thank you.
Can I ask one?
Sorry, Ruta. Yeah, you carry on.
No, please go ahead, sir. Please go ahead.
No, you mentioned. I was just going to make a comment. Yeah.
Yeah. In this procedure, do you come across graft resorption anytime?
Usually not, madam. So far, I haven't come across graft resorption. In tibia, fibula, yes, I try to put few bits around the fibula, but there I have noticed resorption.
And do you recommend to add a plate like James sir showed? So,
I am usually worried about having less space and the plate becoming too conspicuous underneath the skin. So I keep that as plan B. If I'm going for another surgery, then I add that, but usually not as a primary measure.
And I could see your patient was very young. How old was she? Just
2 years, 7 months.
2 years.
7 months.
Okay, yeah. She was quite young. So you usually operate at that age, or?
Usually, yes. With the intramedullary rod, I operate on.
Yeah, I think you can. I mean, though we say from the EPOS and maybe even Benjamin Joseph says in his paper, but I think anyone more than 2 and provided they are reached a reasonable weight, I think they are reasonable to go ahead and have surgery, I suppose. I don't see a problem. The plate, Ashish, is a very low profile plate. And it actually, you can't even feel it quite often because to the subcutaneous plane. And so the very low profile and the screws are locked into the plate, so they don't stick out. So these are very Smith and Nephew plates which have come. They're quite nice. They've got all kinds of sizes from 2 millimeter, 2.4 and 2.7. So you can even use, the only why I use a plate is I'm avoiding a frame, avoiding a cast, to a long cast. That's all it is. So it's actually rotational stability in addition to everything else. Yeah.
Okay.
Dr. Ashish.
Yeah. Yes, please, sir.
From where do you harvest the tibia graft?
So it's from the medial side of the tibia. Usually I go 3-4 centimeters below the proximal physis, and typically around 6 or 8 centimeters long strip, 6 or 8 centimeters long and about 2 centimeters wide.
Is it from the anteromedial surface of the tibia?
More on the medial. I try not to get the apex of the shin.
Okay.
Have you any time used fibula?
No, I haven't used fibula.
Did you use zoledronic acid preoperatively?
No, I am not using zoledronic acid.
Nice case, sir.
Thank you.
Also, when I have done the tibial contralateral graft, you can also get valgus again on that side. So just remember to keep an eye on the other leg. You can calculate the amount of, so basically you divide them into 3s so that at the end you have got 3 strut grafts from that medial surface. So you're actually taking only the medial wall. That's all you're doing. You're still, the anterior shin, the posteromedial shin are all intact. It's a nice way to do it. You can use a very fine 2 millimeter drill and then make tiny, tiny holes in linear fashion. And then again in the middle to split them into 3 or whatever, how many you want to decide. And then accordingly lift them up. And you'll get some cancellous bone as well with that.
How do you fix at the pseudo-arthrotic site, sir? Do you tie with Vicryl or anything?
Yeah, it's like the bamboo hut procedure. Just tie with suture. That's what I do. I don't know what Ashish would have done, but yeah.
No, I don't use anything. I just put some. I just keep some gel foam over it and close the skin.
And for how many days you will immobilize?
Approximately 3 months, but after 2 months, I start them in a weight-bearing cast.
Only after seeing the X-ray?
After seeing the X-ray, yes.
Ashish, when are you planning to change the rod from retrograde to?
So I have little reservations about any kind of growth nails, because I have had problems where the nail has gone distally from the threaded portion and it's very difficult to retrieve it. So usually I'm trying to push that procedure till they are 7 or 8 years old, when they can get at least a 6 millimeter nail.
And do you add cancellous bone graft also?
No, sir, I don't use cancellous bone graft, any additional. Whatever bone comes with that cortical strip, I use that.
Any other questions? So I request Ruta madam to give her concluding remarks.
So this was a great discussion, and I really thank from the bottom of my heart to Dr. James sir. He spared his valuable time. I also thank all the faculty for giving their very valuable inputs, Dr. Nesari, Dr. Wachche, Dr. Ashish, Dr. Mandar. So thank you very much. Ravi, do you want to add any conclusion?
Nothing like that.
Okay.
It was a nice evening.
Yeah. So
Thank
great
you.
job. Well done, Dr. Mandar and Dr. Ashish.
Yeah, well done.
Thank you very much.
Thank
Thank
you.
you very much, everyone.
James,
Thank
sir.
you, everyone.
James, sir.
Thank you everyone.
Thank you,
Ruta
James.
madam. Thank you, James sir.
Good night.
James, sir.
Thank you and good night.
Thank you.
James, sir, kindly share your number, contact number, please.